Good afternoon. Today we're going to talk about diabetic gastroparesis, a troubling ailment that affects many Americans and a common condition, diabetes, and a new medication in the armamentarium against diabetic gastroparesis and the first FDA-approved drug in 40 years to combat this troubling disease entity. The objectives for this meeting, we're going to discuss diabetic gastroparesis challenges through case studies, a brief overview of Gimodi and nasal administration of metoclopramide, and I'm going to give you several case presentations of common clinical scenarios in diabetic gastroparesis, as well as a case discussion and a Evoke Assist summary of how to access the medication. Diabetic gastroparesis, which we'll abbreviate DGP, and the treatment challenges that are associated with managing these very difficult patients that we often see in our clinics on a daily basis. Diabetic gastroparesis continues to pose a huge treatment challenge in the United States. There's 42 million diabetics in the United States, but only a few percentage of these patients are actually diagnosed with diabetic gastroparesis. Even though it's the first autonomic neuropathy and the first neuropathy seen in diabetics, this is a vast underrepresentation of patients that have diabetic gastroparesis. Initially, there's many undiagnosed diabetics, as we know, come to our ERs and subsequently diagnosed years late before a neuropathy has already ensued. So this is a vastly under-recognized entity. It's more common in women, 73% more often occur in women, as is gastroparesis as a whole. And 67% of adults with diabetic gastroparesis are placed on a prokinetic, such as metoclopramide. However, this is a chronic and recurrent condition with flares that occur, leading to ER visits, leading to hospitalizations, leading to a lower quality of life, and really having downstream consequences for the patients that suffer this horrible entity. So patients with diabetic gastroparesis are actually more hospitalized than their counterparts with regular gastroparesis or gastroparesis from other causes called non-diabetic gastroparesis and ICD-10 codes. And why is that? Well, gastroparesis can change blood sugar management, cause episodes of DKA with the inability to take oral medications and acute nausea, vomiting flares. It also can cause hypertensive crises with medications for hypertension being vomited up. So these are the most troubling patients to take care of in our practices. But what if we had a mechanism or new armamentarium that could help these patients from suffering? Many patients with gastroparesis require emergency medical care and hospitalization. I've had patients that often go to the ER and are there multiple times in a month even, or patients that are hospitalized almost 100 to 185 days of the year. So this is a troubling entity, a disabling disease that really has a void for clinical medication use and new advantageous medications and therapy to promote their quality of life. There's 37,000 emergency visits for these patients, increasing cost of care. They're often labeled as pain seekers in the ER, given medications that are for mood stabilizing, depression. In one study, there were patients who were actually admitted an average of 5 days. I've seen many of these patients in my own clinical experience. Everyone sees these patients in their clinic, and gastroenterologists as well as internists, primary care providers, healthcare PAs, and nurse practitioners and mid-levels. What do we do with these patients? What is the proper way to give them a modality to stop this troubling disease? This transitions to the next slide of the treatment algorithm for diabetic gastroparesis. Metoclopramide is the only FDA-approved drug for diabetic gastroparesis. I'll say that one more time. Metoclopramide is the only FDA-approved drug for diabetic gastroparesis. Although there's other treatment modalities that are often employed in these patients, this is a key point regarding to actually whether it's been trialed by the FDA. Sure, if you go through this algorithm, there's dietary modification that usually fails with the low fat, low fiber, infrequent meals. It's very difficult in diabetic patients to find a dietitian that can actually create this plan while controlling their diabetes. Also a big challenge. Sure, glycemic control can occur, but patients can have adequate glycemic control and still have diabetic gastroparesis flares, as I'll show you in these case studies coming up. And there's other medications that can target diabetic gastroparesis, but some of them are not FDA approved in the United States. They'll have to be obtained from Canada. Some of them have been taken off the market. And there's other various formulations that are not FDA approved. So what you have is a huge treatment void in these patients, and there's a role for a new novel therapy, or at least a new mechanism of action to treat patients with diabetic gastroparesis. So do oral therapies make sense in patients who have gastric motility challenges due to diabetic gastroparesis? Well, let's kind of decipher through this. We have patients that have nausea and vomiting and throwing up all their oral medications. That includes their antihypertensives, their glycemic controls, and subsequently, these oral medications such as oral metoclopramide via liquid or tablets are then thrown up in these acute flares. So these medications would not be effective in acute flares of diabetic gastroparesis because it would take them to reach the small intestine, but in fact are actually vomited outward and lose their efficacy of action. What about gastric emptying? So patients have delays in gastric emptying in diabetic gastroparesis patients. Often it takes 4 hours for medication to leave the stomach. So then they're vomiting in within 30 minutes to an hour. So these medications are not going to get absorbed in the small intestine and they're not going to show efficacy. What about rapid emptying or dose dumping? So sometimes this occurs when the medications are held in the stomach and then subsequently are all delivered to the small intestine in a big dose. And this is actually what makes diabetics who have gastroparesis more difficult to manage. They have what seems to be brittle diabetes when really all their medications are being delivered at once, and then they subsequently become hypoglycemic while they were previously hyperglycemic. So this is a huge challenge in this area. So oral therapies have a huge lack of efficacy because of these factors. So 80% of these patients are experiencing vomiting, dry heaving after taking oral medications, and they still are going through these flares. So really, an oral therapy has many challenges due to these factors that are mentioned. So what if there was a way to bypass the GI tract and bypass having to take a medication orally? So this preludes to the nasal administration, really an important way to bring systemic drug delivery. Often in my gastroenterology or motility patients, I'm looking for alternate pathways besides oral, such as sub-Q and nasal. So nasal delivery is growing in popularity. We've seen this in the COPD literature, rapid uptake of systemic therapeutics. So obviously there's advantages of nasal delivery. You have a rapid absorption. You're not dependent on gastric emptying. If patients are vomiting, this is also not affected, and they would still be efficacious in cases of patients with acute flares of diabetic gastroparesis. You don't have to wait for the time to get into the small intestine and be absorbed. This is a non-invasive way as well without having to be sub-Q. And there's a fast onset of action and a high bioavailability very quickly with the nasal administration of medications, which we've seen in other medications that are nasally administered. And it's not dependent on gastric emptying. It's also for the patient comfort. Try to give a patient who's throwing up profusely an oral medication, and that's how these patients end up in the ER. So a nasal administration of this medication provides a unique modality to treat these patients. So what about the acceptance of a nasal administration of medications? In a survey of 98 patient interviews following a phase 2 clinical trial, 74% of patients prefer other mechanisms of taking the medication. This is the nasal formulation of metoclopramide. This was approved in June 2020. The first novel non-oral treatment for diabetic gastroparesis to be approved in 40 years. Jimoti is indicated for the rapid relief of symptoms in patients with acute and recurrent diabetic gastroparesis. Similar to other formulations of metoclopramide, Jimoti does have a boxed warning. The boxed warning is related to tardive dyskinesia, which is a rare disorder, movement disorder. But in the clinical trials for Jimoti, there were no evidence of any patients developing tardive dyskinesia. If any patients were to develop signs of tardive dyskinesia, certainly we would discontinue Jimoti and recommend continuous monitoring. And similar to the ACG guideline with other formulations of metoclopramide, the therapy should be continued for a max of 12 weeks. So what makes Jimoti so unique in its modality and mechanism? This has to do with the novel delivery that is nasally administered. The pharmacokinetics tell the tale. of how Jimodi can give you an advantage in patients with acute flares of diabetic gastroparesis and have an early onset of action. In a pharmacokinetic or PK study in healthy volunteers, metoclopramide was measurable in the systemic circulation earlier when administered as a nasal spray in comparison with the tablet. You can see this graphically represented. At the 15-minute mark, you have concentrations of metoclopramide of approximately 8 versus the oral counterpart, which gives Jimodi a much earlier onset of action. And this is directly what's correlative to preventing and ceasing flares of acute diabetic gastroparesis when these patients are vomiting or heaving and throwing up their oral medications. So we can see that the concentrations of metoclopramide at the 15 and 30-minute mark were higher for Jimodi 15 milligrams in nasal spray in comparison with its 10 milligram counterpart. And similar results were seen in healthy volunteers as well as in patients with diabetic gastroparesis with delayed gastric emptying. So this is the ability of Jimodi and the delivery that is novel that stops these flares and provides relief of symptoms with patients with diabetic gastroparesis despite their poor gastric emptying, and it ceases the symptoms of nausea, vomiting, and abdominal pain. So as we saw on the previous slide, Jimodi's efficacy in healthy volunteers. This is the phase 3 clinical trial of Jimodi's efficacy. The study design was placed in a 1-to-1 placebo-controlled parallel group, a 28-day U.S. study showing the efficacy, safety, and PK of Jimodi in adult women with diabetic gastroparesis and delayed gastric emptying. Basically, this trial dose of Jimodi was 10 milligrams versus placebo. There were 205 patients put in a 1-to-1 randomized ratio. This was conducted prior to the final PK studies were completed and before the FDA approval of the 15 milligram dose of Jimodi. So essentially the study showed was the primary endpoint was to see if there's at week 4 after treatment with Jimodi and diabetic gastroparesis, whether individual symptom scores of nausea, early satiety, prolonged fullness, bloating, and upper abdominal pain were alleviated by Jimodi from a baseline symptom index. And this trial showed that those individual symptoms were in fact alleviated by Jimodi in a women-only study at the 10 milligram dose, which then subsequently paved the way for the future trial dose of 15 milligrams. So this led to the clinical trial with Jimodi in diabetic gastroparesis. Jimodi provided early sustained symptom relief. As you can see from this graphic, you can see the different endpoints with compared to placebo, week 1, 2, 3, and 4. You can see that patients with moderate to severe symptoms of diabetic gastroparesis, that Jimodi provided early and sustained symptom relief. You can see this as early as week 1. In my clinical experience, I've seen this as well in my patients prescribed on Jimodi. I've seen immediate benefits within the first week, which in a field such as diabetic gastroparesis, to me represents a novel breakthrough for my patients treated with diabetic gastroparesis and their nausea, vomiting, abdominal pain symptoms. This is what the total symptom score actually was consisting of: nausea, abdominal bloating, and pain. And you can see reductions in the total symptom score with up to 55% greater improvement in total symptom score compared to patients treated with placebo. You can see at weeks 1, 2, and 3 that the total symptom score was significantly greater in patients treated with Jimodi compared to patients treated with placebo. The improvement was not statistically a group at week 4. However, you can see the first 3 weeks that the efficacy was immediately felt compared to placebo patients. So in patients with moderate severe symptoms of diabetic gastroparesis or DGP, Jimodi provided sustained symptom relief. The primary efficacy point was not met at week 4, but a sub-analysis was conducted of participants who completed the study. These were patients that did not have any missing data. Adult female patients treated with Jimodi had up to 86% greater improvement in total symptom score compared to patients treated with placebo. And specifically, the nausea and abdominal pain, the two toughest symptoms of diabetic gastroparesis, were improved. If you look at patients clinically, the abdominal pain is one of the biggest symptoms that are hard to combat and treat in the clinical setting. And this was significantly improved throughout the study endpoints in weeks 1, 2, and 3, as well as the nausea, which is largely responsible for the acute flares, the ER visits, and then the subsequent hospitalizations. So in my clinical practice, this has made a big difference in ER visits and hospitalizations, with treating the nausea, vomiting, predominant gastroparesis in diabetics, as well as the abdominal pain from gastroparesis in patients. So we began with the first patient of diabetic gastroparesis. This is a 45-year-old African-American female. She was diagnosed with severe diabetic gastroparesis in 2011. She was initially diagnosed with diabetes in 2008. So you see the 3-year gap in her diagnosis of diabetic gastroparesis. This is fairly common in these patients. This is often unrecognized. You'll see that she had numerous ER visits and flares to the hospital, so much so she was hospitalized 143 days of 1 year with recurrent flares occurring in hospitalization, as we've shown in the previous slides, for 5 to 6 days. At some point in time, she was put on antidepressants, pain medications, anti-anxiety meds. Her family started to think that she was having a psychological diagnosis due to the repeated hospitalizations and ER visits with no diagnosis. She became so malnutritioned, her weight loss, she ended up with these repeated flares dropping to a BMI of 17. Her diabetes disappeared, but she still had flares of diabetic gastroparesis. Socially, she was isolated. She was kind of alienated from her family. As I mentioned, she was almost committed, and she was actually even at one point considered for hospice terminal care. She was depressed. She was worried and concerned about having a flare in public, and that she started avoiding social settings. She stopped going to church. She stopped going to family outings, and she was labeled by the ER as someone suffering from severe depression and pain seeking. Which gives us to, what about the safety profile of Gimoti? Gimoti's safety profile, the most common side effect per se was dysgeusia at 15%. There was no difference between Gimoti 15 milligrams versus oral metoclopramide at 10 milligrams in the difference of side effects that could be experienced. Of course, there is the box warning of tardive dyskinesia. However, there were no events of tardive dyskinesia that occurred in the Gimoti trial. In my clinical experience and practice, I've not had any evidence of any patients with tardive dyskinesia with either oral formulations of metoclopramide and as well as in my Gimoti patients. So treatment history, she had been tried on antidepressants, SSRIs, SNRIs. She was put on oral metoclopramide at some point, and she, due to the fact that she was having nausea, vomiting, flares, she was throwing up her medications. She couldn't keep her other medications down as well. She was tried on Phenergan. She was tried on rectal Phenergan. She was tried on liquid versions of it. She was tried on erythromycin for some period of time. She couldn't tolerate the diarrhea and side effects of erythromycin. She was tried on azithromycin as also an alternative. She couldn't have a proper efficacious effect. She was tried on constipation medications as well. Even though her bowels were within normal limit, she was still having episodes of nausea, vomiting. She was tried on Xifaxan, ciproheptadine as well, older antiemetics. She was considered for domperidone, but due to her psychosocial situation, it was not prescribed because she was not going to be able to afford the medication. So what we see is a huge unmet treatment need for someone who's having acute flares of gastroparesis with nausea, vomiting, abdominal pain, numerous ER visits, and she's been tried on every medication that is in the market that was available. And socially, she was depressed, anxious, considered a pain seeker, and avoiding everyone in life and lonely, and to the point that she was put on, even considered for hospice or terminal life care. So what are the next steps in therapy? We have a woman who's suffering from acute flares of diabetic gastroparesis. Her BMI is 17.1. She's having repeated flares to ER and being hospitalized. Despite maximal medical therapy, she's experiencing abdominal pain, nausea, vomiting, and bloating. She's been put on liquid formulations of Reglan, which have helped her, but unfortunately, she's even vomiting those in acute flares of gastroparesis. So she seems to be an ideal candidate for Gimoti, given the fact of the nasal administration and the pharmacokinetics, that the concentration of metoclopramide would be at a reasonable level within 15 minutes of her flare. And so this was considered for her. And she was actually waiting Gimoti's arrival in the market and subsequently accessibility to the medication. And as soon as Jamodi was available, we actually prescribed this for her and saw a immediate effect. It was initially prescribed at the standard dose of 1 spray QID in one of her nostrils, but she actually found out that she was only having to use it twice a day only, and that curbed her flares. She tolerated it extremely well. She really didn't have any issues with the administration nasally. And what were the effect on her symptoms? She subsequently, after she started using Jamodi, she had a reduction of her abdominal pain significantly. She stopped having ER visits. Her nausea was profoundly affected, just as seen in the clinical trials. She was actually able to start eating breakfast again. She was able to tolerate meals. She was able to eat with her family again. She was able to resolve her agoraphobia and make social events, go to church. She actually started cooking again. And this was just for her on the BID dose, which is all was needed for her to reduce her symptoms. She was obviously discontinued on metoclopramide liquid, and as soon as Jamodi was prescribed, and she essentially have all her symptoms abated with just twice daily dosing was all that was needed for her. She tolerated the treatment well and had no issues with any type of side effects during her treatment. What about the impact of therapy of Jamodi on this particular patient? Well, I mentioned the flares ceased. I mentioned all the aspects of her abdominal pain, bloating, and nausea ceasing. I mentioned that now she actually cooks a variety of foods and is able to actually tolerate them and return to her normal life per se and spend time with her family. Remember, previously they had even considered committing her to a facility for these symptoms and also putting her end-of-life care with hospice, meaning terminal diagnosis. And now she has resumed activities and returned to her family and enjoying time with her family. So this was honestly a profound impact on her life. It changed her life in multiple facets in a holistic approach. And that I know that she was continuing to do well now. Okay, so we're going to begin with the second case. We have a 29-year-old African-American male who was diagnosed with type 1 diabetes at the age of 14 in 2006. He had a 5-year delay in his diagnosis of diabetic gastroparesis, which we mentioned generally happens and occurs. So during those 5 years, he had numerous ER visits, kind of similar concept that he was labeled as a drug seeker, was actually hospitalized off and on. He actually went from one hospital to another, different hospitals in the area, which many of us as providers can relate to. He was kind of met with some disdain when he came into the ERs as a drug seeker again. Even though it was known that he had type 1 diabetes, the diagnosis of gastroparesis was not often recognized for at least 5 years. You can see that. So this is kind of what I mentioned previously. These patients are not diagnosed early. So there's a huge need to diagnose these patients in our primary care clinics and, as a nurse practitioner, physician assistant, or as the first line provider for these patients. So he had severe debilitating diabetic gastroparesis with nausea, vomiting, and abdominal pain. His hemoglobin A1C was approximately 7.4. It was considered brittle, and then he went back and forth from hypoglycemia to hyperglycemia. He became depressed due to this. He became isolated. He was often seen in clinic visits with tears in his eyes, upset, even though he was considered a strong individual. He had had a lot of life adverse outcomes. Despite that, he was just suffering from daily nausea, vomiting, abdominal pain. So what has he been treated with? What are the modalities? So this is a patient that is actually treated with multiple, both medical and surgical modalities. He was treated with Zofran, ODT, he's Phenergan rectally, Phenergan liquid, Reglan tablets, Reglan liquid. This didn't work. Erythromycin. He was put on appetite stimulants, Remeron, Lyrica try to treat neuropathy, different Cymbalta, antidepressants, SSRIs, TCAs, anxiety meds. Subsequently, I was able to get him facilitated with a gastric pacemaker, which ameliorated some of his symptoms, but unfortunately, he still had symptoms after. I set him up for pyloroplasty. So he got basically his pylorus was surgically managed. Despite pyloroplasty, he still had flares of diabetic gastroparesis and nausea, vomiting flares. We tried to get him on domperidone from Canada due to his psychosocial situation and not being able to afford the $60 to $100 a month, which is obviously not a small sum when you have multiple medical comorbidities. He could not afford the domperidone. He's been tried on different GI cocktails in the ER, Donatol, pain management, tramadol, injections, celiac plexus blocks. He's been at university hospitals without a cure. He went to 3 university hospitals without any modalities offered. He had pyloric dilations by myself, Botox placed, change of pacemaker leads, battery adjustment, maximization of gastric pacemakers through Medtronic protocol, which is basically the standard. Even despite optimization of all these needs, he still actually had flares of gastroparesis with nausea, vomiting, predominant gastroparesis. And so basically the unmet treatment need is pretty available here, is that he's had acute flares despite maximum medical and surgical therapy and continued ER visits. So what's the rationale for treatment here? Obviously he's having unmet treatment needs despite surgery as well as medical treatment. So he was actually prescribed Gimodi as well. He only had to also take it BID, and he's basically stopped his Reglan liquid. He was able to decrease his daily nausea, vomiting. His abdominal pain, which was one of his worst symptoms, is actually decreased significantly as well, to the point that he actually didn't need to make all his clinic visits, and he stopped going to the ER. So he subsequently also indicated that when he feels like he's about to have a flare, he will take an extra dose of Gimodi. Remember, he's only taking the BID and it's QID indicated, so he will take a third dose if he's feeling the onset of a flare, and this was able to curb his flares. So he was able to sense he was about to have a flare and then subsequently take a dose of Gimodi and subsequently not have that flare go to the ER or need pain medication or IV therapy. So this was a profound effect, in his life. His abdominal pain considerably improved. He no longer needed to have pain management and come to acute clinic visits and ER visits and hospitalizations. So the impact of Gimodi here was profound. Even though his mother had died and he was his primary caretaker, he was actually able to maintain through it, to try to get through that whole episode without deteriorating. And he's still doing reasonably well now. So we have a third patient. We have a 63-year-old African-American female diagnosed with severe diabetic gastroparesis in 2011. She was diagnosed with diabetes in 2008, managed with diet, and her diabetes resolved. She's not taking any medications for diabetes. Her hemoglobin A1C is 5.2. So she initially experienced hospitalizations and ER visits for diabetic gastroparesis. This was actually prior to when I was involved in her care. She had acute flares every 3 months, just with nausea, vomiting, and then less frequent flares of abdominal pain. So this was nausea, vomiting predominant. She was hospitalized for approximately 2 to 3 days. She didn't have many hospitalizations. She had good access to healthcare. And after a while, she started managing these at home. She didn't go to the hospital. She started staying NPO, just taking antiemetics at home, and subsequently took a couple of days off work. But that's how she started managing her flares. So she's a full-time executive. Her husband actually passed away recently from a myocardial infarction. I took care of him as well. So she missed a couple of days of work every time she had a diabetic gastroparesis flare. She took 2-3 days to recover. So, this was time off from work and obviously disabling, keeping away from family events or regular life. And this occurred maybe 3 to 5 times a year. And then some of these she would just manage on the weekend by just being NPO and getting through them basically at home. So treatment history, she managed herself with gastroparesis diet. She was relatively effective. She was well educated and was able to use this initially to manage some of her symptoms, but she still had, breakthrough flares. She was given Zofran, Phenergan, different antiemetics. Erythromycin was tried. Years ago, she had been on Janumet, but then, as I mentioned, she resolved all her diabetes per se, and then was on no medications. So she was actually put on domperidone earlier, and she has access to healthcare. She pays about $60 to $100 a month. She has the ability to afford the medication. She was taking a 10 milligrams AC and QHS, And, this was effective for her gastroparesis, but unfortunately, the cost was expensive. And additionally, she still would have some episodes of these breakthrough flares, but less often. And then as she was able to continue her domperidone, the flares were minimized. But then what occurred was she actually had QT changes on her EKG in a primary care visit. They were concerned. She had a cardiology evaluation to see if domperidone was the cause. Cardiology was consulted, and they actually asked the domperidone to be discontinued. They didn't find any structural evidence of heart disease, and they felt that the QT interval changes would be better served by not being on chronic domperidone. I remember her husband also died of an MI, myocardial infarction. So she was suggested to be on an alternative agent. So this is a patient with that's her unmet treatment need. And the question would be, what agent would you consider in this situation? And this would be a candidate we would consider for Gimodi, given the fact that there's no monitoring of the QT intervals similar to domperidone, baseline EKGs, and additionally that this is also a medication she can get within the United States. She can also, it's FDA approved for gastroparesis in diabetics. This is based on evidence-based criteria, and there's no investigational drug patent that you would need for domperidone for patients that are similar in this situation. So access is limited to domperidone. It's not approved in the United States. So this was a patient we considered for Gimodi in the future. So what about access to Gimodi? Well, Gimodi has a unique program with Evoke Assist with support for patients and physicians. Essentially, what you see is there's a commitment to making access for patients in that either there's a $20 copay or there's a $0 copay. If insurance covers Gimodi, it'll be a $0 copay. If insurance doesn't cover Gimodi, there's a cash paying ability to be $20 for the copay. In my clinical experience, everyone that I have prescribed Gimodi to was able to get on the medication, regardless of insurance versus financial need. They were able to facilitate being on the medication. In the era of access to medications and very expensive medications, I find that in my clinical practice, the access to medication has been excellent for patients suffering with diabetic gastroparesis. In an era of difficult access to medications, prior authorizations, and medications prescribed by providers not being covered by insurance, and patients not being able to get a medication on a different insurance plan, Gimodi has a unique avenue that through Evoke Assist. Essentially, the patient, if it's covered, Gimodi will be $0 for the patient in terms of a copay. If it is not covered, the patient will only pay $20 as a copay. So the access to medications is either one of these two pathways, no copay or a $20 copay. So in my clinical practice, everyone that I was prescribing Gimodi for and prescribed Gimodi for was able to have access to the medication, which is novel in this day and age, given prior auth insurance coverage. So there's other avenues for accessibility to Gimodi. There's Evoke Assist support group program for your patients. You have benefit verification, nursing support, education. There's abilities to check insurance, free home delivery. I've utilized that many times for my patients. They were able to have the medication delivered to their home and have access to talk to different individuals to educate them about the medication. So this is a great avenue for your patients. I've utilized this several times. For practice providers, there's the Evoke Assist support program on the website that can also be accessed. And we've been able to get accessibility to the medication in such that everyone who prescribe the medication has been able to get the medication as well as take the medication, have support through it.
Important safety information. Indication. Gimodi metoclopramide nasal spray is indicated for the relief of symptoms in adults with acute and recurrent diabetic gastroparesis. Limitations of use. Gimodi is not recommended for use in pediatric patients, in patients with moderate or severe hepatic impairment, in patients with moderate or severe renal impairment, or in patients concurrently using strong CYP2D6 inhibitors. Boxed warning, tardive dyskinesia. Metoclopramide can cause tardive dyskinesia, TD, a serious movement disorder that is often irreversible. The risk of developing TD increases with duration of treatment and total cumulative dosage. Discontinue Jimoti in patients who develop signs or symptoms of TD. In some patients, symptoms may lessen or resolve after metoclopramide is stopped. Avoid treatment with metoclopramide, all dosage forms and routes of administration, for longer than 12 weeks because of an increased risk of developing TD with longer-term use. Contraindications. Jimoti is contraindicated in patients with a history of TD or a dystonic reaction to metoclopramide when the stimulation of gastrointestinal motility might be dangerous, e.g. in the presence of gastrointestinal hemorrhage, mechanical obstruction, or perforation. In patients with pheochromocytoma or other catecholamine-releasing paragangliomas, metoclopramide may cause a hypertensive pheochromocytoma crisis, probably due to release of catecholamines from the tumor. In patients with epilepsy, metoclopramide may increase the frequency and severity of seizures. In patients with hypersensitivity to metoclopramide, reactions have included laryngeal and glossal angioedema and bronchospasm. Warning and precautions. Tardive dyskinesia, TD. Metoclopramide can cause TD, a syndrome of potentially irreversible involuntary movements of the face or tongue, and sometimes of the trunk and/or extremities. The risk of developing TD and the likelihood that TD will become irreversible increases with the duration of treatment and the total cumulative dosage. The risk of developing TD is increased in the elderly, especially elderly women, and in patients with diabetes mellitus. Due to the risk of developing TD, avoid treatment with metoclopramide for longer than 12 weeks. Jimoti is not recommended in geriatric patients as initial therapy. See full prescribing information for switching geriatric patients on a stable dose of an alternative metoclopramide product to Jimoti. Other extrapyramidal symptoms, EPS. In addition to TD, metoclopramide may cause other EPS, Parkinsonian symptoms, and motor restlessness. Advise patients to seek immediate medical attention if such symptoms occur and to discontinue Jimoti. Neuroleptic malignant syndrome, NMS. Metoclopramide may cause a potentially fatal symptom complex called NMS. Clinical manifestations of NMS include hyperpyrexia, muscle rigidity, altered mental status, and manifestations of autonomic instability, irregular pulse or blood pressure, tachycardia, diaphoresis, and cardiac arrhythmias. Additional signs may include elevated creatine phosphokinase, myoglobinuria, rhabdomyolysis, and acute renal failure. Patients with such symptoms should be evaluated immediately. Avoid Jimoti in patients receiving other drugs associated with NMS, including typical and atypical antipsychotics. Depression. Depression has occurred in metoclopramide-treated patients with and without a history of depression. Symptoms have included suicidal ideation and suicide. Avoid Jimoti use in patients with a history of depression. Hypertension. Metoclopramide may elevate blood pressure and should be avoided in patients with hypertension or in patients taking monoamine oxidase inhibitors, MAOIs. Discontinue Jimoti in any patient with a rapid rise in blood pressure. Fluid retention. Because metoclopramide produces a transient increase in plasma aldosterone, patients with cirrhosis or congestive heart failure may be at risk of developing fluid retention and volume overload. Discontinue Jimoti if any of these adverse reactions occur. Hyperprolactinemia. As with other dopamine D2 receptor antagonists, metoclopramide elevates prolactin levels and may suppress pituitary gonadotropin secretion. This may inhibit reproductive function by impairing gonadal steroidogenesis in both female and male patients. Galactorrhea, amenorrhea, gynecomastia, and impotence have been reported with prolactin-elevating drugs, including metoclopramide. Effects on the ability to drive and operate machinery. Metoclopramide may impair the mental and/or physical abilities required for the performance of hazardous tasks, such as operating machinery or driving a motor vehicle. Concomitant use of CNS depressants or drugs associated with EPS may increase this effect, e.g. alcohol, sedatives, hypnotics, opiates, and anxiolytics. Avoid Jimoti or the interacting drug, depending on the importance of the drug to the patient. Adverse reactions. The most common adverse reactions in patients treated with Jimoti are dysgeusia, headache, and fatigue. In patients receiving an equivalent oral dose of metoclopramide, the most common adverse reactions were restlessness, drowsiness, fatigue, and lassitude. Adverse reactions involving the nervous system occurred after stopping oral metoclopramide, including dizziness, nervousness, and headaches. Drug interactions. Avoid concomitant use with antipsychotics, MAOIs, and central nervous system CNS depressants. Concomitant use with strong CYP2D6 inhibitors, for example, quinidine, bupropion, fluoxetine, paroxetine, is not recommended. Use with caution with dopaminergic agonists and drugs that increase dopamine concentration. Monitor for reduced therapeutic effect when used with drugs that may have opposing effects on gastrointestinal motility, for example, antiperistaltics, anticholinergics, opiates. Monitor patients receiving Jimoti for increased blood glucose and adjust insulin dose regimen as needed. Use in specific populations. Pregnancy. Published studies do not report a consistent pattern or a consistently increased risk of pregnancy-related adverse outcomes with oral use of metoclopramide during pregnancy. There are potential risks to the neonate during delivery following exposure to metoclopramide in utero. Lactation. Breastfed infants exposed to metoclopramide have experienced gastrointestinal adverse reactions, including intestinal discomfort and increased intestinal gas formation. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for Jimoti and any potential adverse effects on the breastfed child from Jimoti or from the underlying maternal condition. Pediatric. Metoclopramide is not recommended for use in pediatric patients due to the risk of TD and other EPS, as well as the risk of methemoglobinemia in neonates. Geriatric. Elderly patients are more likely to have decreased renal function and may be more sensitive to the therapeutic or adverse effects of metoclopramide, especially older women. Jimoti is not recommended as initial therapy. Renal impairment. Jimoti is not recommended in patients with moderate and severe renal impairment. Hepatic impairment. Jimoti is not recommended in patients with moderate or severe hepatic impairment. NADH cytochrome B5 reductase deficiency. Metoclopramide-treated patients with NADH cytochrome B5 reductase deficiency are at an increased risk of developing methemoglobinemia and/or sulfhemoglobinemia. CYP2D6 poor metabolizers. Jimoti is not recommended in patients who are CYP2D6 poor metabolizers. Please see complete prescribing information, including boxed warning, medication guide, and patient information at JimotiRxHCP.com. You may report side effects related to Evoke Pharma products by calling 1-833-4-JIMOTI, 1-833-444-6684, or emailing jimotimedinfo@evokepharma.com. If you prefer to report side effects to the FDA, either visit www.fda.gov/medwatch or call 1-800-FDA-1088. Reference: Jimoti metoclopramide nasal spray. Prescribing information: Solana Beach, California. Evoke Pharma Incorporated, 2021.